Telling us that we did the fastest case yesterday.
Yeah, we were just lollygagging around.
And the patient just got up and walked right out of the OR.
Yeah,
Are you excited about doing this when you get back?
I am. I mean, it's very interesting. And I was we were just chatting, and I overheard you talking about one of your mentors, who was a mentor to all of us, Dr. Tebbets, and I was just interested how you think this new technique kind of builds upon kind of those core principles that he outlined, and how it's almost the next step in the evolution of what we are offering our patients.
His number one thing was not to damage the breast and to emphasize that the best predictor of long-term outcomes was the preservation of soft tissue. He always said it is to not, did he use the word preserve? It was the thickness of soft tissue coverage is most predictive of a long-term result. And implant size and not overly dissecting were the hallmarks of that, and this procedure emphasizes that.
So then for our patients, I think the biggest thing is going to be, they obviously will get a great result, but I'm wondering, are they going to have a better result now, 5, 10, 20 years down the road? How do you think this manifests for the patients? Why is this beneficial for our patients?
So for the short term, I think the benefits are going to be an easier recovery, less pain, faster recovery. I think that they'll be able to get volume placed where they are lacking volume. See, right now, when we put in volume, it starts from the bottom and builds up.
Always.
Because our pockets always start at the inframammary fold, and then it builds up. But, I mean, I get patients, I'm sure, you get patients who are like, I don't want to be that much bigger, I want it.
Or they want it just in their upper poles.
Right, It's like, I don't like that I emptied out, but I don't want to be a lot bigger.
Right.
This is the first time we're using the tissue within the breast to support an implant a little higher up than we were ever able to do before.
Yep. And it's interesting because the way that this is being done, before we were doing submuscular dissection, now a lot of people are talking about subfascial dissection. So in some ways you're delaminating the breast even less. So you're disrupting anatomy potentially even less, and being very strategic in how you're doing that. How about our patients yesterday? You had mentioned that Our Lady was up and out. We're the quickest surgeons too, which is,
Well
pat
trained.
ourselves on the back. But
And we were bloodless, there wasn't a drop of blood, right? Speed only matters if you do it well.
not a drop of blood. And what was interesting, one of the patients was at the reception last night, and I mean, just moving around, looking great. And then the result too doesn't look, odd. It looks good on table.
It is true that they selected the most perfect models for us to work on yesterday. All of them started out looking about as good as a lot of my patients hope thereafter looks like.
Right.
So, but one of the problems that I have promoting this is that already I do a no narcotic, Tebbets based, 24-hour return to normal activities. Patients shower the night of surgery, read to their kids, they can be intimate the night of surgery, they drive in 2 days, they go back to work in 4 days, and they fully exercise in 2 to 3 weeks. So I have to figure out a way, because a lot to say that this is somehow better than what I already do, but a lot of what I talk about is how they already have a great recovery. So I have to find a way to still defend and be proud of what I'm doing, but still show an incremental benefit to this.
Yeah. And I think part of which I'm at least seeing from an intuitive standpoint, is that the approach is in some ways less traumatic, because you're doing, if you can get a bloodless, blunt dissection, cautery there's some level of trauma associated with that, and so maybe that's one of the reasons why patients are more comfortable. But this idea of strategic volumization and not disrupting the anatomy.
Well, good word, strategic volumization, that's very good.
And I think that's really intrigues me, because I think the biggest things we want to have like stable long-term results. And I mean, how much of your practice you do, I'm sure a tremendous amount of secondary, tertiary, quaternary breast, that it's just because of that initial intervention, that primary intervention, that likely leads to this kind of downstream effect and all these more difficult operative interventions that become almost reconstructive procedures. If we can obviate that.
They all become reconstructive procedures, and they're sometimes more difficult than a mastectomy reconstruction, because most of the mastectomy reconstructions, I mean, some had implants, but usually they're not starting out with damaged tissue. These people, the muscle's damaged, the skin's damaged, and the breast tissue is damaged. But the interesting thing you're getting at is that this is still creating a new plane that you can't create another way. Subfascial, prefascial, the implant is still stuck in position with nothing behind it that can move.
Right.
Sort of like we were talking before about how like the palm of your hand doesn't move much. This technique allows for just a few fat cells and a little bit of areolar tissue to remain so that the implant has that little bit.
Right.
You know, when they talk about femtech, you know, about from the woman, the person, the owner, the possessor of the implant, it feeling like a natural part of her body. This
Right.
implant, and you can't dissect it any other way because that space between the fascia and the posterior lamella is very thin.
Right.
And unless you expand it with tumescent solution, you can't get there. And have you ever tried Boving in the middle of
No.
a tumescent thing? It just
It's a-
bubbles
yeah.
and
it frustrates you because your cautery doesn't work well.
right.
No, I think that's very interesting. It's almost, you know, they use this kind of thought of like being biomimetic, but I think the biggest thing is that implant, this is what you're getting at too, is gonna move with that patient and the breast. It's funny when you have that kind of phenomena where, you know, breast moves independent of the device, that's dead giveaway. And I think that's an intriguing thing for patients, and I think, you know, they're feeling in their chest to not have that kind of foreign feeling. You know, how many times when you have patients where if you do like an explant on, and they're just like, oh, I feel so good to have that gone, that mass effect, and that kind of, you know, it behaving like something different. I think if we can make them behave like one, I think that's a really intriguing thing as well.
Do you think that this is an alternative to patients who would already be getting an augmentation with you, or do you think that this provides anything to someone who wasn't satisfied with what options they had in the past, so that there are people who will consider it now who would have never before?
I think it should open a huge segment of individuals who've just thought about it, who were unaware that they can essentially get a small volume enhancement, like when they put a bra on and has a little bit of padding in there. It can be used for larger though, as we were demonstrating yesterday. But I think this idea too, and you know, we all do, you know, augmentations under sedation type protocols, and a lot of times we prefer general anesthesia. But I think I would be more comfortable using lighter levels of anesthesia with this. You know, I think maybe you could do it under full local, although I would never want to do that on my, you know, if I was having this procedure, which I'm not, but just because of the
I
experience.
can tell you though, I've done liposuction breast reduction under full local on, you know, generally more anxious later teenage women, and it's interesting. It's very hard, of course, to get the cannula through the parenchyma, but I've done. It's funny, the dissection yesterday I've done many times because these people, when you lift the breast up to the ceiling, that's a very easy minute. So where we want the anesthesia,
It's
and
just
where is happens to be in the right
Right.
place.
I think that's the big thing, is like, how many patients have you seen, or, you know, like when we see a lot of these people are maybe moms, they have kids, and they're so critical in their household, and they're just so mortified about having to get general anesthesia, and like, that's the holdback. I think these patients would totally be, I think would take that step, feel like this is gonna be more of a procedure, it's still surgery, don't get me
Right.
wrong, but the idea of not having to have general anesthesia and literally just, you know, being with it and waking up, or not having to even worry about wake up, I think there's some real value proposition there, and I think that you're gonna get more and more people who'll be willing to do this. And I think even the technique, I mean, just think about it, we didn't use cautery at all yesterday. And there was an issue, and you're a control freak, I know, I've been to so many of your lectures, and I'm the same way, and I mean, you look at it, there's no bleeding. And I think that, that's pretty interesting, and so it's a lot more simple. You know, it's almost too simple, like, you know, is this really gonna be that easy to do? What did you think about the analogy of it's almost like targeted fat grafting?
I didn't hear that. Explain that.
Yeah, so it was one of the ideas, like, so that, you know, not, you know, normally you put, like you were saying, you put that implant, and typically it's gonna fill that kind of central breast, be centered retroareolar long-term, but this idea of when you can make a focused dissection pocket, where you can put it in the upper, you know, inner quadrant or upper medial quadrant, and it stay there, and it almost mimics when you're trying to do, you know, upper pole fat grafting. I thought that was an interesting concept. I'm like, it's kind of TBD to see if that.
All right, but
really
I'll
stays
show
that
that.
way.
But I also have a concern about it, which, you know, I can reduce the concern by starting out with smaller implants in people with better coverage.
Mhm.
But we've all seen a capsular contracture where the implant is high, or we've seen a patient with a transaxillary augmentation where the inframammary folds were the subpectoral where the inframammary fold wasn't taken down and the implant is superiorly malpositioned, right? So you've seen people with a bulge here and nipples are sort of tipped down, where you can't wait to lower the implant down to here. We can't forget that we see that. And Manuel is a great surgeon I trust, says he's not seeing that. And it may be that using ergonomics implants in front of the muscle, the way they behave, the way they taper, this isn't an issue.
Right.
But I can't imagine that at some size in some breasts, you are going to create, you will have more superior medial fill relative to infralateral fill.
Right.
It's like the breast they showed yesterday had more lower lateral fill, so we could put more superior medial fill.
Right.
But the answer also is, though, I'm thinking out loud, is, well, but you also can put the implant more central. You don't, and there are people, and I guess it's more typically the postpartum person who asks for the upper fullness because her volume has dropped down and out. You can put her up and in. I'm thinking out loud.
Yeah, no, it makes sense. I think the other thing too is with these devices, and also just a little bit of a paradigm shift. Not really a shift, but it's almost like things that a lot of us were doing in practice, where you obviously always want to avoid over dissection laterally, especially in the pre-pectoral space, and like kind of really kind of exaggerating that is probably for the best period. You know what I mean? To avoid that, because long term, when people lay down, you know, you get that lateral descent, and I think it'd be interesting to see how stable these really are, because I think you want a certain degree, and I think that what you don't want torpedoes. When people lay down, the breast should have some level of relaxation, but then you don't want to have that, you know, sternal show. And I think that at least what we're hearing, what we're seeing from their results, that there's a pretty good amount of stability, and I think that's an important piece as well.
You make a good point. There's an ideal amount, and I need to think for myself of a better way to describe to patients what an ideal amount is. In other words, no one wants them to fall onto the bed. And no one wants them to stick straight up like a fembot, right? And there's a healthy amount. And I think by preserving the ligaments and having glide behind the implant, it will move with the way the breast moves. And it's interesting, Manuel talked about the angle of divergence of the chest from the sternum. Remember, he had 127 to 28 degrees. I will document patients that like that, and I always say your chest like the roof of a house, so when you lay on your back, a ball on the roof is, and so there's some people who are going to go out more, but really limiting that lateral dissection. I think a key thing to this has to do with that there's some minor motion behind the implant, like I'm showing with my hand on the dorsum of your hand, and I can't wait to see that play out.
Right, because ideally that implant shouldn't be stationary. It should kind of have some level of movement, but not, you know, swimming in a big old pocket that could lead to all the other downstream effects.
And there are two things that surgeons still are going to have to take into account that's not fully worked out. One is, you know, one of Tebbett's emphasis was on the forward stretch and the fill of the breast. You know, there's always an emphasis on width, and in what we've learned this way, only talked about width. There's no analysis of the 3 dimensions, right? There's a difference between an 11 centimeter breast with a nipple to fold of 6 and a nipple to fold of 9. There's a very different breast that you can grasp medial to the areola and easily, without discomfort, pull it forward 3.5 centimeters, or not be able to pull it a half without causing discomfort. And people think only of the width, and they go, oh, it's a width of 10. I can either pick one of these 3 sizes according to 3 profiles. That has to be considered. And then the second thing is understanding the thickness of the tissue coverage, because most of the patients who would want this don't want to see a delineated edge. So when you talked about the fat grafting to the upper pole, the difference is that fat grafting is always going to be smooth and blended. There's no, because you feather it. This is 100% not feathered. Now, an ergonomics implant will, quote unquote, feather better than a standard implant, but it's not. But it still has a discrete boundary.
And I think that'll be, you know, other thing is obviously there's things downstream that'll be less obvious, where the ergonomics 2, for example, that have the different shell behavior. But I think that, at least from the ones we saw yesterday, the thickness about 1.5 centimeters is thinner than we normally would consider, right, historically. And I think that's a remarkable thing. I'm sure what's been your experience in just the subfascial space in your thickness now? Are you still do you still have a hard and fast thickness that you'll follow, or you're less thick than you used to be with some of these newer devices?
So the two main reasons for going behind the muscle were coverage and capsular contracture. And from the international data, because the US data was mostly behind the muscle, but the same CapCon rates are reported in other trials in front. So it's probably not an issue.
Yeah.
I don't know if it's equivocal, I think equivalent, yeah. But I don't yet have, I know that we have a little bit more room, but I also know in cases where I've been going subfascial, where a year ago I would have gone behind the muscle, I do see a little more delineated edge on the table. And it's given me a little in my stomach in the OR.
Yeah.
But when I see them back in a month, there's enough stretch and redraping, and the patients have all been happy. Submuscular and premuscular is always going to be trade-offs. Those patients have less pain and zero animation deformity and better expansion of the breast. So even if there's a little more visibility. But there are some patients who come in and go, I want it totally undetectable. I want, if anything, a little scoop. I don't want any, they don't use this word, I think of a point of deflection, inflection point.
Right.
Or I think an M point was the term that Manuel uses for that. And if they want none of that, then the problem part with all of this is we should have gotten so good behind the muscle with standard techniques that pain and sensation of this and recovery should be improved, but we should already be so awesome that we don't want people to be afraid of what we've been doing. We just want them more enthused about this.
Right. Totally agree.
What's your first patient going to be? Like, who do you want to see as your ideal first patient?
I would want to see, obviously, be a primary aug. I would not want to do a mastopexy with it just for the first one.
For
and
sure.
I think, ideally, someone who has a distensible soft tissue envelope, but not, I'd probably say nulliparous. Someone who wants a small volume breast aug would be great. Ideally,
Why nulliparous
symmetric.
more than a non-todic Paris?
Oh, actually, I'd take that. That'd probably be the best because you get easy distensibility. Don't have to worry about it being too tight. But I think a low volume, something 150 to 200 cc aug would be great. I think that it should be a straightforward thing to accomplish. I was just, it was just so smooth and so quick. Like we've talked about before. An augmentation is normally fast in general, but your goal is not to go fast. Your goal is to get a great outcome and have control. But we were kind of, going at a slow pace, but it was even quicker because of the technique of how it's dissected, and there's a couple steps that are eliminated, like multiple, evaluations using, direct visualization. All those things take a little bit of time. So I think that from a precision standpoint, even if the patient has to get anesthesia, you're shaving off operative time, and all those things, have a potential lower risk profile.
Incision length matters.
It does matter. Well, you're disrupting less of the breast soft tissue envelope and parenchyma. This idea of preservation. Literally, your incision is going through.
Look at the difference between, now I know there's muscle involved, but look at the difference in recovery, for instance, of a standard appendectomy and a laparoscopic appendectomy.
100%.
Lap chole and an open chole. Well, a Coker incision, an incision for a gallbladder is, of course, traditional one was a huge incision. But, and blood is the key thing for pain. Tebbett's emphasized that, but we know that, like a woman can middle schmerz and ovulate, and 2 drops of blood can land her in the emergency room, and everybody's worried she has appendicitis or ruptured this or that. And every drop of blood you avoid. And remember, there's 2 steps to this being hemostatic. One is the epinephrine, 3 steps: the epinephrine, the compressive sort of negative tourniquet effect of the volume expansion, and then the pressure of the balloon.
And the other thing too is that we were talking. There's been such a pendulum shift in the U.S. and worldwide into the prepectoral space being subfascial. But I would have to think though, and this is probably why the patients are doing so well and their anesthesia requirements so small. I mean, the fascia, when you're doing a subfascial dissection, there's still, spasm of the muscle. There's pain receptors there, but the actual, plane that we've been talking about, that kind of that posterior lamella, I mean, you're going to have less discomfort.
Look, when you bovie, I don't know, if you bovie, let's say you had a perfect bovie, it's obviously going to be more 11 centimeter diameter thing. You have, what's that? It's pi r squared. So it's 5 squared times 25 square centimeters of heat injury. Okay, you go buzz any part of your body with the cautery, there's got to be discomfort to it.
And inflammation and all these other things that are going on where I bet all that is mitigated in this situation.
By the way, there's another thing that helps with the hemostasis that I was just thinking. We talked about the volume of fluid, the epinephrine, the balloon, but then since it's a tight pocket and you have the implant completely filling the pocket, you actually have pressure against the walls of it from the implant. And people say, well, it's true of all implants. Not exactly, because the dissector balloon is fit to the implant, because you're preserving fibers. Like, when you close an aug, subpectoral or prepectoral, as carefully, there's always some space.
Yeah. And they always, have that reported sense of a little bit of fluid or air in there.
That's interesting. Patients always, not always, but you get calls every month. They'll tell me, I hear a gurgling, swishing. It's because there's implant a little air and a little bit of fluid. I bet they'll never have that.
I agree, because there's just no place for it to be, and the pocket is so tight.
Right. You can't sharply dissect a pocket this tight. So that's interesting. And look, he's done a lot. And it's the same tunnel with the MIA, with the minimally invasive axilla. They have this thing, right? And there's a huge experience with that, and they don't have hematomas.
Yeah, it's interesting.
It's very hard, after so many years preaching that blunt blind dissection is wrong, to understand that this is not the blunt blind dissection technique that I learned and I castigated for so many years. It's a new technique. We need to come up with a better word for it than blunt. It's not exactly blunt.
Yeah.
It's not sharp. It's not cutting.
Atraumatic
Spreading.
But it's interesting.
Finding a natural plane.
But the reason why, though, I think that was the case, though, is that even if you could have done it then, you didn't have the proper, not necessarily instrumentation, you didn't have the proper device or the proper technology to support it. You know what I mean? The problem is if you went in there and you put in whatever the older generation devices were, it wouldn't work in that situation. You wouldn't utilize a saline device in that situation.
Right, we didn't have the right implant. We didn't have something to make the tunnel with. We didn't have a balloon on a stick that we can control. So what's going to happen. People are going to say, I'll just use a saline sizer.
Mm-hmm. You're going to get uncontrolled expansion in who knows what vector and what orientation.
I mean, with this, remember, like, we put it in and Pablo said, do it a little more medial. I mean, just, so, I took a little bit out and I just angled my hand that's where you want it.
Right.
So blunt was supposed to be imprecise.
Right.
They need to find a better term, like natural tissue plane augmentation. We're putting it in a natural plane right behind the posterior lamella, between the fascia and the lamella, in a plane that has a little bit of glide and slip to it.
Awesome.